Next on our program is Dr. Christopher Zammit. This is the first time that Dr. Zammit has actually spoken to our group, and today he's going to share about the impact of COVID-19 on stroke and aneurysm risk. Dr. Zammit is the medical director of the Stroke and Neurosciences Intensive Care Unit at Good Samaritan Hospital and Acute Neurologic Emergencies for TriHealth. Thank you so much for being here, Dr. Zammit. You may turn on your webcam, share your screen, and begin your talk.
All right, can everyone hear me still?
Yep, you sound wonderful. Go ahead.
Okay, fantastic. Thank you for that. So I am honored and thrilled to be here to speak to you on this topic. Thank you again for inviting me. Thank you for the introduction. I apologize for the background. I don't mean to state the following as suggesting that any of this is an inconvenience. We're kind of jumping between taking my kids to their soccer games this morning, and so my broadcast location is a little suboptimal. But like I said, I'm thrilled to be able to speak to you all on this topic, and I'm really honored to be here. So certainly wanted to make it a priority. Yeah, and this is a great topic, the impact of COVID-19 on stroke and aneurysm risk. I certainly recognize that I'm speaking to a group of people who have had a lot of personal experience with brain aneurysms, ruptured aneurysms, producing subarachnoid hemorrhage as a form of stroke. This topic that I'll be speaking to you all about today, it really will capture a lot more of the aspects of stroke in general. And so I'll walk through a little bit of that. I suspect that given the prevalence of stroke in our community, many of you have had personal experiences with patients who have had stroke, whether those are friends, family members, or even our friends and family members who have other people who are close to them, and perhaps there's even people with personal experiences with suffering other forms of stroke than just an aneurysm rupture. I state that as a introductory statement on this because that is really where we've seen a lot of the impact of COVID-19. So with that said, I'll get to it. So really there's three major kind of areas where we want to talk about, where I want to convey to you about the relationship between COVID-19 and stroke. One, there is some evidence that COVID-19 in and of itself can be causative of a stroke. And that the COVID-19 pandemic was substantially associated with delays in the presentation of patients with stroke, or even non-presentation altogether, which resulted in some unfortunate outcomes for stroke victims. And the COVID-19 pandemic has also produced some additional stressors on our system that have also not only led to an increase in stroke-related mortality and morbidity, but even in other healthcare conditions, other acute conditions, and even the management of chronic diseases as well. So to set the stage here, I want to make sure that we all are familiar with what are really four major subtypes of stroke. One is an acute ischemic stroke, which is due to a blockage of blood flow to a part of the brain, which will lead to that part of the brain rapidly dying unless blood flow is restored. Two, a second form of stroke, actually, that many of you may have heard about in relationship to some of the association with the adenovirus vector COVID-19 vaccines, is cortical venous thrombosis, or sometimes it's called thoracosinus thrombosis. And that's due to a clot forming not in the arterial supply to the brain, but to the venous drainage from the brain. I'll go into a little more detail here shortly. A third type is what's called an intracerebral hemorrhage, and this is where someone has suffered a stroke due to the sudden rupture of a blood vessel in the brain. It's not due to trauma, and this is different from an aneurysm. This is where typically one of the very small blood vessels has ruptured and bled. However, that there's caveats. 60% of the time it's due to a rupture of a small blood vessel. 40% of the time it's due to one of many other causes. And it requires a lot of investigation on our part of the hospital in order to determine the cause of it. And the subarachnoid hemorrhage, which I think that many of you are more familiar with, given the this is being the brain aneurysm symposium, is most often related to the rupture of a brain aneurysm. 85% of the time, a subarachnoid hemorrhage is caused by the rupture of a brain aneurysm. 15% of the time, it is caused by the rupture of a blood vessel for a different reason other than aneurysm. So there are some non-aneurysmal subarachnoid hemorrhages, but by and large, a subarachnoid hemorrhage is the result of a ruptured aneurysm. Now, when it comes to COVID-19 and stroke, really, the major issue with the association between stroke and COVID-19 is related to thrombosis. So thrombosis is the formation of really a blood clot, which sometimes is appropriate. Obviously, we have an injury to one of our blood vessels. We need a blood clot to form to plug that hole and to stop hemorrhaging from happening wherever that is. For instance, if an aneurysm ruptures, we do want our body's natural system of forming a thrombus right at the hole that was formed when an aneurysm ruptured to form and to plug up that hole temporarily until surgical techniques can be used to further secure that aneurysm, as we say, or to prevent its recurrence from bleeding. Same thing with, again, if you have an intracerebral hemorrhage and there's one of the blood vessels that ruptured, we need our thrombosis system to be activated. However, many diseases are caused by the inappropriate formation of thrombus. And COVID-19 has been particularly notorious, or you could say infamous, for its association with thrombosis. There's this concept in medicine that describes the three different underlying pathologies that tend to contribute to the inappropriate formation of thrombosis, and that's been called the Virchow's Triad. This goes back over 100 years when this was described. And so, those three factors are related to vascular damage, so that's any kind of injury to our blood vessels, hypercoagulation, and that's due to different levels of or activation of the proteins in our blood and the cells in our blood that help us to form blood clots to produce a thrombosis. And then there's stasis. So if blood becomes static or has sluggish flow, it's also more likely to form blood clots. So maintaining a good, consistent flow is protective against the inappropriate formation of thrombus. And in the setting of COVID-19, we've really found that all three of these are potentially impacted. The vasculature in the body has been described to undergo some damage, which I'll show here a little bit more on the following slide. That there's factors that cause the levels of many of the factors in our blood, those proteins, to be elevated or hyperactive. And there's places in our body where blood can become more static, and one of those is particularly in the heart. There's been it's been known that COVID-19 can cause some direct inflammation of the heart itself, causing the heart not to pump correctly. And when the heart's not pumping correctly, then the blood won't move through it as efficiently, which can increase the risk for clots forming. And if those clots break off, they can go into the brain or other areas of the body. So again, COVID-19 really has pathologic underpinnings for each one of the areas of Virchow's Triad. This is an illustration from a paper that summarized some of the pathologies, some of the underlying mechanisms that lead to the formation of thrombus. Now, this illustration is particularly showing the formation of thrombus directly in the lungs, because the thrombosis issues that we've seen with COVID-19, they're not restricted to, let's say, going to the brain. They are actually a part of the pathology of the tremendous challenges and issues that we have with maintaining oxygen levels in the blood of patients who are suffering from severe COVID-19 that require hospitalization. So in this illustration, what you see at the top of the slide is what's represented as what's called the alveoli. These are the tiny little grape-like sacs in the lung that we breathe air into. And as you can see, that there's an illustration there of the actual COVID-19 virus. This is the lining of the lungs. This is called the epithelium, and this is where the virus enters through, and then it gets through what's called the interstitium, and then eventually into our blood. And these cells that you see below it in red are the endothelial cells. And these are the cells that line the surface of our blood vessels. If these endothelial cells become injured, damaged, or even just activated through some things on the surface of the brain, the surface of the cells, it can lead them to then produce factors that enhance inflammation, that cause our immune system. And these things that you see here on the slide, the monocytes and the neutrophils, these are all cells in our blood that are meant to produce our immune response. Well, when this immune response is produced, all these other factors in the blood called interleukins, tumor necrosis factor, and other things called cytokines, they increase in the blood, which also then activate the proteins that form these clots. And that's what you see, the ultimate consequence here at the bottom are these clots forming in the blood. And this is a representation of those clots forming directly in the blood vessels in the lungs. But this inflammatory cascade, this immunologically mediated cascade, is not restricted to the lungs. It occurs throughout the body. And really, those who suffer the most severe complications of COVID-19, it's actually less related to the virus causing direct damage in the body. It's actually more related to the immune response that our body produces to the virus that becomes so profound and so powerful that it actually causes collateral damage in the rest of our body. And that, again, that collateral damage is producing the same inflammatory response, which in those with mild COVID, or mild COVID would be the right word for it, would have their response more restricted to more the lungs. But those who have more pronounced, more severe illness will have that response really that gets carried out throughout our body. Now, this concept of COVID-19 also causing this problem is not actually idiosyncratic from a virus standpoint to COVID-19 or the SARS-CoV-2 virus. It's actually something that's been described as related to several other viruses. Influenza actually has a known association with increasing the risk for stroke and heart attacks, really via a somewhat similar mechanism, where really it's the revving up of our immune system, which then increases the possibility for thrombus to form, and for our endothelium to become what's called destabilized and be more likely to produce, cause clots to form, again, causing strokes and heart attacks. And actually, there's been a known association with those who continue to get their influenza vaccine, that with a reduced risk of stroke and heart attack. So those who consistently get their flu shot every year actually have a lower risk of having a stroke and a heart attack. Mostly because, as you know, when we make the influenza vaccine, we're kind of guessing as to what the strain is going to be that year. But the more previous years you've been vaccinated, the more likely you are to be protected, because the strains that come around for influenza tend to reappear over years. So again, the more years you're vaccinated against the flu, each year the better protected you'll be. The conversation with influenza vaccine oftentimes involves, oh, the flu shot this year and how good it is at protecting this year's flu. But actually, your cumulative previous vaccinations against COVID or against influenza are also protective. So again, the concept here is that if we can allow our body the opportunity to minimize the possibility of having one of these more profound or strong immune responses against a virus, we are able to then protect ourselves against some of these cardiovascular and cerebrovascular events. So again, these are the two types of strokes, really. Of the four types of strokes, it's really the ones that are related to thrombosis that have had their association with COVID-19. Now, the incidence or the occurrence of intracerebral hemorrhage and subarachnoid hemorrhage have not been described to have increased with COVID-19. However, I will share later that the mortality and the consequences from having an intracerebral hemorrhage and subarachnoid hemorrhage have at times likely been worsened due to not merely the virus, but due to what has happened with our society and healthcare system's response to the pandemic itself. And I'll talk about that more here in a second. So again, with an acute ischemic stroke, again, this is due to a block of arterial blood flow. So the blood that's supplying the brain, this is bringing nutrients, it's bringing oxygen to the brain to sustain the brain tissue. Some other background that's really important, which many of you may know, but just to make sure, is that the brain requires a tremendous amount of energy to function. it actually continuously requires 20 to 25% of our energy expenditure in any one day, short of if we did significant physical exertion. And so when the brain has blood flow blocked to any part of it, the brain tissue that was supposed to be supplied by that blood vessel will rapidly die. And it will be much more likely to be irreversibly lost as a result of that occlusion. This is another illustration where you can see that there can be a blockage of a variety of blood flow. This is a blood vessel known as the carotid artery bringing blood flow into the brain. This is the largest one. As you can see, you can have a thrombus that forms and even what's called embolizes, where it travels up through that blood vessel, blocking a small blood vessel. At times, these very tiny hair-like blood vessels can form thrombus within themselves, and that can cause what are called lacunar infarcts. But again, so the thrombus can either form within the blood vessel itself or come from another part of the body and travel to the brain. And the formation of thromboses within the blood vessels of the brain can occur in the large vessels or the small vessels. Again, this is an illustration of some of those atherosclerotic changes that we know that can develop over time. And when you have this, the endothelium is particularly sensitive. So this is where if you have someone with known risk factors for stroke or heart attack, and they have some of this already existing plaque, and then you have a virus like COVID-19, you're even more likely to cause destabilization of this endothelial barrier, and what's called destabilization of this plaque, which then can accelerate the formation of thrombus, causing strokes and heart attacks. These are some of the symptoms of stroke. Stroke is a difficult disease to educate our community on because it's not like some other diseases where the symptoms that are produced by it are somewhat narrow. And this is the symptoms that you see here for ischemic stroke. They also are symptoms that you can see with hemorrhagic stroke, with the intracerebral hemorrhage, and also, as again many of you know, is also with aneurysm rupture as well. It just depends on which part of the brain and the brain tissue are impacted by that. So this is where we typically are reaching out to our community, being very proactive and getting people's attention, reminding people that these are the kind of symptoms that if they occur particularly suddenly and without any clear underlying reason, that these are very suggestive of being a stroke and really would warrant the promptly seeking medical attention. I mentioned before cerebral venous thrombosis. Again, the veins help to drain blood away from the brain. These larger ones that you see running down the center of the brain, particularly you'll see an area here labeled the confluence of sinuses. These are what are called the cerebral venous sinuses. They are the major sort of thoroughfares, if you will, of blood draining away from the brain. These smaller blood vessels that you'll see draining into those larger ones, those are what are called cortical veins. And the thrombus can develop in either one of them. Particularly if one of these major sinuses is occluded, then the blood flow that's supposed to be draining out of the brain gets backed up. It causes swelling in the area of the brain where that blood flow is supposed to be coming from, and then that swelling can even lead to hemorrhage. The other way that swelling can cause problems is that if there's a lot of back pressure from the blood trying to drain out, it blocks the inflow of blood into that area, so you can actually produce an ischemic stroke due to a blockage of the venous outflow as well. Now, the symptoms from a cerebral venous thrombus tend to be more related to the swelling and edema that occurs from it, and potentially the hemorrhage. So patients are more likely to complain of a headache with vomiting, having a depressed level of consciousness where they're lethargic or even in a coma. They're much more likely to present with seizures, and patients would be much more likely to be described as just being confused, where they're unable to make sense of things, or they're not quite making statements that are understandable. Now, the cerebral venous thrombus, again, I want to address one thing with this when it comes to COVID-19. There had been an association between cerebral venous thrombosis and COVID-19 vaccination. The association is really with the adenovirus vector COVID-19 vaccines. The association with it is quite small. It's actually the result of a idiosyncratic and uncommon immune response to the adenovirus. It's not really so much to the COVID-19 portion of it. It's to the adenovirus, because there's been a couple of other adenovirus vaccines that also were trialed in Europe that were not in the United States that also has these similar findings. And basically, there's this immune response from the adenovirus ones that cause the immune system to then ping the platelets in our blood. The platelets help to generate clot. And then the platelets, actually, the platelet count by their activation, they actually end up getting what's called consumed. So if you were to measure somebody's blood, the platelet count is actually low, even though they're forming clots, particularly in the cerebral venous sinuses. This was quite uncommon with the adenovirus vaccine. And when they tried to investigate this with the mRNA vaccines, which are more commonly referred to as the Pfizer and the Moderna vaccines, there has not been noted to be an association. Now, I think it is really important to share with you all that there was a recent study looking at the comparison of the rate of cerebrovenous thrombosis in patients who had COVID-19 and who were unvaccinated as compared to those who had one of the adenovirus vector vaccines. And the actual risk of developing a cerebral venous thrombosis if you had COVID-19 and were unvaccinated was 36 times higher than if you had the adenovirus vector vaccine. So it's again, COVID-19 in and of itself is much more thrombogenic and produces a much greater risk of forming these thromboses than the adenovirus vector vaccine. I think it's important to kind of put that in a relational perspective. So which brings to, like, how do we mitigate the risk of stroke with COVID? Well, really there's two major ways, and really what you want to try to do is you want to avoid the robust immune response to COVID. And again, really when you first get exposed to COVID, it gets into your body. Oftentimes there's a period where we have minimal to no symptoms, and then we begin to have symptoms. And during that very early period, the virus is beginning to ramp up its replication in our bodies. And of course, if we're vaccinated, it helps us to quickly jump in front of that replication and have an adequate immune response to suppress the virus from ever getting to very high levels that would produce a very strong or robust immune response. The additional medications or medical interventions that also have been now found to also reduce the risk for having more severe COVID, which is more associated with developing these strokes, are the antivirals. So these are some of the pills that you've seen in the market. And then also what are called the monoclonal antibodies. And these are where we have the infusion centers where you can go in and you can get an infusion of antibodies against COVID-19. And there's also actually an antiviral infusion as well. And so particularly for those who are at higher risk for having more severe COVID, if you are diagnosed with COVID early, then these antivirals and or monoclonal antibodies have been shown to reduce your risk of getting severe COVID, and therefore would reduce your risk of having a stroke. So between vaccination and knowing if you have the virus when you do become symptomatic, particularly if you're at higher risk, these are the kind of things that you can do to reduce the risk of a stroke. There have been several studies looking at if we could use other medications that we may use to prevent stroke in COVID-19, particularly with blood thinners, one of them being called Eliquis, and also known as Apixaban, and then just good old aspirin. A study of aspirin, unfortunately, did not prove to show benefit in those with COVID-19. And also a study that was funded by the National Institute of Health looking at anticoagulants in those who could be at home with COVID-19 also did not show benefits. Now, this is different than if you're in the hospital. There's more nuanced and sophisticated treatments that we offer to those in the hospital if you end up having severe COVID-19. So my comments on this are really for those who have COVID-19 but can still be at home. So again, it's really, of course, vaccination reduces your possibility of having severe COVID-19. If you do develop COVID and you have risk factors for it, talking with your doctor about getting one of the antivirals or monoclonal antibodies will further reduce your risk. And then, unfortunately, right now, we don't have any kind of studies or data to confirm that aspirin or other blood thinners reduce the risk of COVID-19 related complications in those who do not require hospitalization. Now, I do want to talk a little bit more about ischemic stroke. Again, I know that this that you all are have a lot of personal familiarity with aneurysm and aneurysm rupture. But given that COVID-19 association is particularly with ischemic stroke, I do want to spend a minute and talk about how exquisitely time-sensitive ischemic stroke is. Again, ischemic stroke being due to a blockage of blood flow to a part of the brain. And there are two major treatments that we can offer patients to help quickly restore blood flow to the brain. These treatments are extremely time-dependent and are really just available to those who present very early after the onset of symptoms. So if you present too late, which is not several days, but just a few hours too late, then you may not even be eligible for the treatment. But if you present, it'll show here, just 15 minutes later, you are doing yourself a significant disservice if your symptoms are disabling. So this is a paper that's talked about a lot. It's from 2006 in one of our core journals called Stroke, where Jeffrey Saver sought to quantify what the rate of lost neurons are in the brain when someone suffers a stroke. And this is where you oftentimes will hear that when someone is suffering a stroke, they're losing nearly 2 million neurons per minute, or 32,000 per second. And again, this is just a way to, I guess, really bring home the point that that when a stroke is occurring, that brain cells are dying very, very quickly. Again, there's two major treatments for stroke. If someone's having an ischemic stroke, excuse me. One of them is a medication that is right now the most commonly used medication is called TPA. There's another one called tenecteplase, which is very similar to it. But they're both medications that aren't just blood thinners. They go beyond that. They're medications that actively break up blood clots. So there is risk with these. There is a risk of causing hemorrhaging. And that risk of hemorrhage goes up the longer it takes for you to get that medication. Now, on the contrary, if you have a very large blood vessel that's blocked, then you could be amenable to surgical treatment for that. And that's where we go in through what are called endovascular techniques. We enter the blood vessel typically through the groin, and we snake some wires and catheters up into the blood vessels of the brain, and we use some devices to literally pull out the blood clot. Again, this is really reserved for when very large blood vessels are blocked. The majority of strokes are not amenable to this. The majority of strokes are in blood vessels that are too small to be treated with mechanical thrombectomy, so they require treatment with the medication TPA or tenecteplase. And these are some illustrations of the exquisite time sensitivity of these therapies. So on the left side of the screen, you see the descriptions from the published data on the effectiveness of alteplase, also known as TPA, in stroke. And you see, just with a 15-minute delay in treatment from the onset of symptoms to treatment, if you reduce that time, you will reduce the chance of someone dying from stroke. You'll reduce the complications related to that stroke, particularly the most feared complication being causing a symptomatic intracerebral hemorrhage. If you treat somebody 15 minutes faster, you'll increase the probability that they'll be able to walk on their own, and you'll increase the probability that their symptoms will be mild enough or even fully resolved so they can go back home after their stroke admission. It's profound, and I really can't emphasize enough how tremendous this is. 15 minutes is enough to make this difference. We too often see patients who waited longer with their symptoms. They presented late because they wanted to see how things were going. They didn't call 911. Instead, they called a family member or someone else to get advice on their symptoms or to come and get them and bring them to the hospital. Calling 911 is always much faster. It may at the moment not quite feel like it because you're calling and you're waiting for 911 to get there, for the EMS to get there. But once EMS gets there, they can call ahead to the hospital. We can get you registered before you're even at the hospital, and we can begin to look into your medical record and enter orders for things to be done when you arrive at the hospital. Versus if you drive by a private car and you go to the front desk, nobody knows you're coming. We don't have the proper information. You're not registered in the electronic health record. There's a lot of reasons why coming by EMS helps to hasten treatment. So again, not waiting on symptoms is really important. And unfortunately, during COVID, patients did. This is the effectiveness also of the mechanical thrombectomy, the surgical treatment for the large blood vessel blockages. And what you see in the y-axis here, this is a proportion of patients who had what's determined to be a good functional outcome. The scale we use is something called the modified Rankin scale, where a 0 on the modified Rankin means 0 symptoms. A 1 means you have some residual neurologic symptoms, but they don't prevent you from doing anything you could do before. You can go back to living life the same way you were living before, even though you might have some neurologic symptoms that are left. And a modified Rankin score of 2 is where you did lose the ability to do something, but you still have full functional independence. You can live by yourself, you can still do your job, all those kind of things. So for us, anyone who suffers from a stroke, our goal is to get folks preferably to a 0 to 1, but at least to a 0 to 2. That's always our goal. As you can see, that there's a quick deterioration in the probability of a patient getting mechanical thrombectomy and achieving a modified Rankin score of 0 to 2. You see, as you go from a rate of about 83% down to around 80%, and pretty quickly, as you get to 2 hours later, you go from 83% down to about 60%. So that's a 23% reduction, absolute reduction. So 1 in 4 patients, if they're treated at 180 minutes versus at 60 minutes, will not achieve this outcome. 1 in 4. That's a significant proportion, and we want to have as many folks as close to this as possible. Unfortunately, what we found during COVID was that patients were not coming to the hospital. So in the red here, this is right before COVID, the months before COVID, and in the green here, these are the months during COVID, and these are the number of patients presenting per week with strokes, and you see that the number dropped off during COVID. Additionally, as you can see here, when patients did present with strokes, they on average presented 121 minutes later. They waited to come in. 121 minutes. I mean, I just emphasized the importance of 15 minutes and the TPA treatment. And I showed how with 121 minutes that 1 in 4 patients who require mechanical thrombectomy will no longer see the benefit of achieving that independent outcome from their stroke. So this was a very unfortunate complication or consequence of early COVID in the systems. And actually, these are data that actually we contributed to at Good Samaritan Hospital, and that Dr. Andrew Ringer with the Mayfield Clinic, he has a national research group called the Endovascular Research Group, Energy, who were the ones who conducted this study, and we contributed data from Good Samaritan Hospital to this multi-center study. Furthermore, to further bring home the consequences of COVID on cerebrovascular and mortality, this was a study, again, in stroke, our major journal we use for sharing stroke knowledge, where we found that there was really this excess in cerebrovascular mortality of up to 7.8% above levels in the early period after COVID. And again, as described, this is another study that found with different data that the number of people calling 911 to go to the hospital for stroke went down, and that for every 1,000 less calls, there were 70 excess deaths at 1 week, and there were 85 excess deaths at 2 weeks for every 1,000 less EMS calls. Again, just further emphasizing the importance of calling early, getting to the hospital, because multiple data sets from multiple states have shown that that during COVID, people were concerned about coming to the hospital and they waited with their symptoms, and that did have unfortunate consequences. Now, unfortunately, this of course wouldn't just extend to stroke. People with other medical illnesses also were not seeking attention, and whether this was an emergency or even managing their chronic medical conditions. And so what has overall been observed is that during COVID-19, not only did we see an increase in deaths in the United States related to COVID-19, but we saw an increase in deaths related to non-COVID related illnesses. This was a paper in the Journal of the American Medical Association that illustrated this excess deaths, and they broke it down by different geographic regions, since the pandemic has had different burdens in different areas of the country at different times. As you can see, the number of excess deaths was quite pronounced in some areas of the country, particularly during some of the busier points in the pandemic. Now, of these excess deaths, about 3 out of 4 of them were related to COVID-19. They were assigned to being a COVID-related 19 death or complication, but about a quarter of them were not assigned to be related to COVID-19, which could imply that either this is a very late complication of someone who had COVID-19. It could be somebody who had, again, a non-COVID related illness, or that they died before they could get diagnosed with COVID-19. So it's hard to say of this 27.6% increase in excess deaths during this period, if this was purely non-COVID related. I think that most of us are persuaded to say that many of them were non-COVID related based upon what we were observing in the hospitals, and particularly with the observed consequences that we saw, particularly in the stroke population that I just shared. So kind of some final thoughts here. So kind of what we have learned during the COVID-19 pandemic is, first, that healthcare systems have limited capacity to absorb large regional, state, and national surges in acute and critical illness. That mitigating disease in a pandemic that would is critical if that disease would burden the acute healthcare systems. However, keeping healthcare services open and welcoming is critical despite an infectious pandemic. And again, I think that all of our healthcare systems experienced some of the economic stressors that also occurred when healthcare resources and the rest of our economy was not able to be sustained. So certainly, I hope we all can, as a healthcare community, can learn a lot from our experience with COVID-19, so that we can continue to provide our best care to patients, even with non-COVID-19 related illnesses, while still managing the pandemic in a way that the hospital and the resources of the hospital don't become overwhelmed and unable to provide the kind of care and focus that you need, not just for the COVID-19 victims, but also for those who are suffering from non-COVID related illnesses. And again, the association, particularly between COVID-19 and stroke, is that a lot of this association is related to the immunologic activation when the virus invades the body, which causes these vascular events, these events in our blood vessels. And that really preventing this viral invasion or minimizing it will prevent this disease. It is worth saying that there are other viruses that also are associated with stroke. The herpes zoster virus that causes chickenpox and shingles is causative of stroke, and some of the other herpes viruses, one called HHV6, also has been associated with stroke. In addition to my comments already on not only COVID-19 but on influenza. And so, I know specifically to this group, I know I wish there was more I could say about the relationship between COVID-19 and aneurysm formation. However, to this point, there's not anything well described in the literature about the relationship between COVID-19 and aneurysms directly in and of themselves. However, again, given the fact that the other viruses are known to irritate and cause vascular injury, there is some degree of biologic plausibility to this, and that hopefully in the future, healthcare community can investigate the possible relationship between this further. But as of right now, I do not have anything objectively to share with you all on a direct relationship between COVID-19 and aneurysms. All right. Well, thank you very much, and I'll be happy to take questions if we have some time.
Thank you, Dr. Zammit. That was very interesting. We do have questions for you. The first question: if I have a flow diversion stent for my aneurysm, does COVID infection cause my blood to stick to it?
So good question. If you were to develop more severe illness, there could be an increased risk for that to occur. Obviously, that's significantly mitigated with the antiplatelet agents that you'd be taking for a flow diverting stent. So we do not have data to say whether or not having COVID-19 while on antiplatelets it increases the risk for a thrombus in the stent. You could always be concerned about the possibility of that, and obviously doing whatever you can to avoid COVID-19 would be best to minimize the increased risk. But theoretically, the answer would be yes. Theoretically, there could be an increased risk of forming a thrombus on that flow diverting stent.
Okay, next question. If I understand you correctly, COVID doesn't cause stroke, but it does make the blood more sticky, thrombose, if you happen to suffer a stroke. Does this mean TPA is less effective in COVID positive people?
We don't have anything to suggest that TPA is less effective. there's many diseases. Really for ischemic stroke, the result of that is always a thrombus occurring, so the blood becoming more sticky, and many of those are in conditions that are related to it. The thing that is far more predictive of the effectiveness in a medication like TPA to break up that blood clot is how old that blood clot is. The longer the blood clot has been sitting there, the more time it's had to mature and harden and become more resistant to a medical intervention like TPA. So I don't know that I would say, nor do I know of any data to say that that a COVID-19 related thrombus is definitely more resistant to TPA. But I would like to emphasize that the earlier you get treated with TPA in relation to the formation of the thrombus, the more likely the thrombus is going to dissolve and the blood flow will be restored.
Okay, last question. You spoke about lack of evidence for COVID causing aneurysm. What about any evidence, even anecdotal, that COVID or long COVID increases risk of rupture of known pre-existing aneurysm?
Yeah, I mean, there's so I guess I'll take a step back here for a second. There's when it comes to aneurysms in and of themselves and their risk of rupturing, there's several different features of the aneurysms that are contributory to the potential for rupture. And one of among those risk factors is actually inflammation of the aneurysm itself. So that's where theoretically that's that kind of that biologic plausibility term there that you could say, well, COVID-19 in and of itself does cause a very robust immune response that would increase inflammation. Could that cause a destabilization of an aneurysm and make it more likely to rupture? You certainly could say that. Right now, there's been several studies looking at if there's been an increase occurrence of subarachnoid hemorrhage and intercerebral hemorrhage in COVID-19 as compared to those who don't have COVID-19. Right now, none of the studies have really found that to be the case. Again, the findings are much more related to the ischemic events. Again, but I don't know. Just because you have negative studies, it doesn't mean it's not possible. You have to. A negative study doesn't always disprove something. It just may fail to prove something. It depends how the question was asked. I don't know that the questions that have been asked have totally excluded that possibility.
Thank you so much, Dr. Zammit. That will conclude this part of our presentation. We appreciate you participating today.
Yeah, again, I'm really glad to be here, and thank you for the opportunity to contribute.